Welcome to this e-course on creating an enabling environment for HIV services for adolescents, young people, and key populations. A summary of the UNAIDS People-Centered 2025 targets and the UNAIDS Global AIDS Strategy 2021 to 2026 with a focus on young people. This training is intended for providers of HIV care for adolescents, young people, and key populations in resource-limited settings, including clinicians, nurses, pharmacists, and community health workers, and for communities of people living with and affected by HIV. Webinars and workshops, where possible, may include a mixed audience of clinic staff and community members. It aims to enhance participants' ability to provide evidence-based, appropriate, quality, accessible HIV services to adolescents, young people, and key populations. The purpose of this training is to summarize the UNAIDS 2025 targets, which put people living with HIV and communities at risk at the center of the response. After completing this training, you will be able to describe the new UNAIDS 2025 targets, explain the barriers and facilitators to the implementation of people-centered and adolescent-friendly services in the context of the new UNAIDS targets, and identify peer-driven models of care in the implementation of services for adolescents, young people, and key populations. Let's start by taking a look at the UNAIDS 2025 targets. COVID-19 has put the world even further behind its efforts to end HIV/AIDS by 2030. As the fast-track era draws to a close, UNAIDS has worked with partners to develop a set of proposed targets for 2025. The UNAIDS 2025 targets place people living with HIV and communities at risk at the center of the response. Call for 95% coverage of a core set of evidence-based HIV services. Set clear targets for the removal of societal and legal barriers to accessing services, and emphasize the importance of integrating the HIV response with efforts to achieve universal health coverage of the Sustainable Development Goals. The proposed targets for 2025 fall into three categories. First, comprehensive HIV services. Second, removal of societal and legal impediments to an enabling environment for HIV services. And third, people-centered, context-specific service integration. The 2025 targets place far greater emphasis on removing societal and legal impediments to service delivery, and on linking or integrating the provision of HIV services with other services that people living with HIV and communities at risk need to stay healthy and build sustainable livelihoods. Achieving the targets for societal enablers and integrated service delivery are critical to achieving the high coverage called for within the HIV service targets. Let's take a look at each of these three domains more closely. Domain 1 is comprehensive HIV services, the 95s. Comprehensive, high-quality HIV services are the core of the HIV response. The 2025 HIV service targets are placed into categories, but in reality there is considerable overlap between them. This reflects the fact that there are no clear divisions among HIV prevention, testing and treatment, the prevention of vertical transmission, and sexual and reproductive health services. As the 90-90-90 targets were the most successful element of the fast-track agenda, new testing and treatment targets for 2025 maintain the same overall approach, but adopt the more ambitious 95% objectives. They also clarify the need for achieving these targets within each subpopulation of people living with HIV. The 2025 testing and treatment targets include people living with HIV within all subpopulations and age groups, and aim to achieve 95% of all PL-HIV know their HIV status. 95% of PL-HIV who know their status initiate treatment. 95% on treatment are virally suppressed. In place of the long-standing reliance on generalized facility-based testing, responses are increasingly emphasizing differentiated testing models, including diverse facility and community-based approaches that can focus on communities at greatest risk and be tailored to individual and community needs. Active adherence support, community and provider monitoring of those lost to follow-up, and strategies for re-engagement that are context-specific and people-centered have been shown to reduce program attrition and increase rates of viral suppression. Innovative strategies to reach underserved subpopulations include focused outreach and testing services on high-traffic areas frequented by men or young people, community hubs to reach underserved men, comprehensive men's health and sexuality counseling to make services more appealing to men, altering outreach hours to increase the likelihood of engaging more men, and programs specifically designed for female sex workers and other key populations. The recent ATLAS and FLAIR trials demonstrate that monthly injection with the drugs cabotegravir and rilpivirine are as effective as daily oral therapy, offering a treatment approach that may be simpler and more convenient than oral daily dosing. In addition, a robust research pipeline continues to investigate new antiretroviral medicines, including those from additional classes. The UNAIDS 2025 targets clarify the need for achieving the 95-95-95 targets within each subpopulation of people living with HIV. These subpopulations include children aged 0 to 14 years, adolescents and young people aged 15 to 24 years, adult women 25 years and older, adult men aged 25 years and older, people on the move, such as migrants and refugees, gay men and other men who... The UNAIDS 2025 targets clarify the need for achieving the 95-95-95 targets within each subpopulation of people living with HIV. These subpopulations include children aged 0 to 14 years, adolescents and young people aged 15 to 24 years, adult women 25 years and older, adult men aged 25 years and older, people on the move such as migrants and refugees, gay men and other men who have sex with men, transgender people, sex workers, people who inject drugs, and people in prisons and other closed settings. The UNAIDS 2025 targets prioritize sexual and reproductive health services for women living with HIV and women at elevated risk of HIV infection, and they reinvigorate the global push to eliminate new HIV infections among children and ensure that children living with HIV have timely access to life-saving treatment services. The 2025 targets include meeting sexual and reproductive health service needs and eliminating vertical transmission of HIV. 95% of women of reproductive age have their HIV and SRH service needs met. 95% of pregnant and breastfeeding women living with HIV have suppressed viral loads. 95% of HIV-exposed children are tested. Sexual and reproductive health services are critical for preventing HIV acquisition through sexual intercourse and mother-to-child HIV transmission during pregnancy, childbirth, and breastfeeding. Changes are needed to better serve adolescent girls and women at high risk of acquiring HIV who are accessing contraception. Adolescent girls and women should have more contraceptive choices available in all types of service delivery settings, including family planning clinics and primary healthcare clinics. Adolescent girls and women accessing contraceptive services, especially in high HIV-burdened countries, should have easy and affordable access to prevention and treatment services and quality integrated HIV and STI testing that are responsive to their rights and preferences. The updated WHO recommendations for contraceptive eligibility for women at high risk of HIV should be disseminated widely and followed. The rights of adolescent girls and women to full and unbiased information should be guaranteed in all healthcare settings and in the community. Contraceptive, HIV, and STI services need to be part of a broader health response that includes services for primary health care and for sexual and reproductive health and rights in the context of universal health coverage. In high HIV burden settings, women's risk of HIV acquisition increases during pregnancy. More frequent testing, including during the third trimester and in the postpartum period, can reveal recent seroconversions and ensure rapid initiation of antiretroviral therapy to improve the mother's health and prevent HIV transmission to her child. The substantial number of children who are living with HIV but not receiving treatment stems from a combination of low coverage of early infant diagnostic services and inadequate implementation of multiple testing strategies to find older children who acquired HIV while breastfeeding after 2 months of age, or those who may have been missed by early infant diagnostic efforts. Point-of-care early infant diagnostic platforms should be brought to scale quickly. Where this is not feasible, turnaround times for early infant diagnostic results from a centralized laboratory must be reduced through improved specimen collection and the use of mobile technologies. For older children who are missed by early infant diagnostic services, family testing strategies are urgently needed. Detailed targets include women of reproductive age, pregnant and breastfeeding women living with HIV, and children aged 0 to 14 years. 95% of women of reproductive age in high HIV prevalence settings within key populations and living with HIV have their HIV prevention and sexual and reproductive health service needs met. 95% of pregnant women are tested for HIV, syphilis, and hepatitis B surface antigen at least once during pregnancy and as early as possible. In high HIV burden settings, 95% of pregnant and breastfeeding women with unknown HIV status or who previously tested HIV negative should be retested during late pregnancy, the third trimester, and in the postpartum period. 90% of women living with HIV are on antiretroviral therapy before their current pregnancy. All pregnant women living with HIV are diagnosed and on antiretroviral therapy, and 95% achieve viral suppression before delivery. All breastfeeding women living with HIV are diagnosed and on antiretroviral therapy, and 95% achieve viral suppression to be measured at 6 to 12 months. 95% of HIV-exposed infants receive a virologic test, and their parents are provided the results by age 2 months and between ages 9 to 18 months. 95, 95, 95 testing and treatment targets are achieved among children living with HIV. HIV transmission dynamics differ greatly across and within regions and countries. They also vary by modes of transmission and within and between population groups. Effective HIV prevention requires a granular combination approach that is differentiated according to location, population group, and risk of HIV acquisition. Combination prevention recognizes that individuals need to be provided with a choice of multiple tools to prevent HIV infection, including behavioral and biomedical approaches, to ensure that at least one will fit their current needs. Such choices are not fixed. The most appropriate tool will vary with the specific situation. The 2025 prevention targets include all subpopulations and age groups. 95% of people at risk of HIV infection use appropriate, prioritized, person-centered, and effective combination prevention options. The failure to date of expanded treatment access to achieve rapid reductions in HIV incidence has underscored the critical importance of primary HIV prevention. However, political support for HIV prevention is still lacking due to numerous factors, including the inherent complexity of HIV prevention, challenges in measuring impact by showing that something, HIV infection, did not occur, lack of comfort in addressing issues of sexuality and drug use, especially among young people, and the fact that prevention needs are often greatest among populations that are socially marginalized and politically disfavored. Effective HIV prevention involves a combination approach that offers multiple prevention options to people at risk of HIV. Efforts to reach the 95-95-95 testing and treatment targets must be combined with robust efforts to scale up condom promotion, comprehensive sexuality education, voluntary medical male circumcision, PrEP, harm reduction, and newer methods such as the Depivirine vaginal ring and long-acting injectable PrEP. Research continues to generate new tools and approaches for HIV prevention. The Depivirine vaginal ring has been found by 2 studies to reduce women's risk of acquiring HIV by more than a quarter. The European Medicines Agency has endorsed the ring, and it is rapidly moving into implementation. Long-acting injectable cabotegravir for PrEP has been shown in 2 studies to be superior to oral PrEP in preventing new HIV infections. Efforts to design and evaluate preventive HIV vaccines continue, although it is anticipated that a preventive vaccine for HIV remains several years away at the very earliest. In summary, the targets for comprehensive HIV services, or 95s, fall into 3 categories: HIV testing and treatment, sexual and reproductive health services, and combination prevention options. The greater attention paid to subpopulations of people living with HIV reflects the current heterogeneity of testing and treatment coverage across these populations, which undermines the population-level preventative impact of treatment. Young people are less likely than older adults to know their HIV status and access treatment. Similarly, many key populations also have poorer outcomes across the 90-90-90 cascade, due in part to the effects of stigma, discrimination, and structural factors. Domain 2, removal of societal and legal barriers, the 10s. The high levels of HIV service coverage called for in the 2025 targets can only be achieved within an environment where people living with HIV and people at risk of HIV infection feel safe to utilize those services. Unfortunately, this is currently not the case in many countries. The criminalization of drug use, sex work, and same-sex sexual relationships, HIV-related stigma and discrimination, and gender inequality are powerful barriers to HIV services. The 2025 targets emphasize that countries must invest in specific efforts to remove these impediments and establish an enabling environment that is free of societal, political, legal, and economic barriers. The 2025 targets for removal of societal and legal barriers are placed into 3 categories: punitive laws and policies, stigma and discrimination, gender inequality, and violence. This target area aims to build on and accelerate momentum towards legal reform and access to justice in numerous countries and regions, applying lessons learned more broadly to bring legal and policy frameworks into line with the human rights underpinnings of an effective HIV response. The targets aim to achieve by 2025 less than 10% of countries criminalize sex work, possession of small amounts of drugs, same-sex sexual behavior, and HIV transmission, exposure, or non-disclosure. Less than 10% of countries lack mechanisms for people living with HIV and key populations to report abuse and discrimination and seek redress. Less than 10% of people living with HIV and key populations lack access to legal services. More than 90% of people living with HIV who experienced rights abuses have sought redress. Severe criminal penalties for same-sex relationships are associated with a 4.7 times higher risk of HIV infection compared with settings that do not have such penalties. In addition, the existence of laws that marginalize or criminalize LGBTQ people is also associated with substantially lower uptake of HIV testing services. Similarly, repressive laws regarding sex work are linked with increased HIV prevalence. Criminalization of drug use is associated with increased risk of HIV. Decriminalization is a long-term process that unfolds along a continuum, offering the possibility of interim successes prior to the ultimate removal of criminal sanctions. Decriminalization itself is not the end of this process, but rather an intermediate critical step towards the ultimate goal of creating environments that are just, equitable, and enabling for an effective people-centered response. Punitive, discriminatory, and scientifically unsound laws are the norm globally, and they have especially dire consequences for key populations. But recent experiences have underscored the feasibility of decriminalization and other forms of legal reform. Since 2016, Chile, Pakistan, and Uruguay have formally recognized gender identity and introduced legal protections for transgender people. Senegal has legalized sex work. Globally, the number of countries and territories that have HIV-related restrictions in place for entry, stay, or residence decreased to 48 in 2019. Countries such as Antigua, Barbuda, Belize, Colombia, Mexico, South Africa, and various states in the United States have relaxed long-standing drug laws. The number of countries criminalizing same-sex relationships has continued to decline in recent years. Since 2016, Colombia and Mexico have removed or relaxed HIV criminalization laws, while Belarus, Canada, and the Democratic Republic of the Congo reduced the situations in which people living with HIV may be prosecuted or convicted. More concerted efforts are needed to learn how legal reform has occurred and to understand how to apply and individualize these approaches to other settings. Learning from recent successes can help identify optimal messages, effective strategies, and ways to combine with broader social changes in order to encourage legal reform. In particular, countries that have recently enacted legal reform can encourage neighboring countries to take similar actions. Stigma and discrimination. This new target aims to reduce sharply the prevalence of HIV-related stigma and discrimination. Taking account of the growing HIV burden among key populations and the pernicious effects of stigma and discrimination on efforts to address the HIV-related needs of key populations, this target area includes more detailed, population-specific targets. The targets aim to achieve by 2025. Less than 10% of people living with HIV report internalized stigma. Less than 10% of people living with HIV report experiencing stigma and discrimination in healthcare and community settings. Less than 10% of key populations, for example, gay men and other men who have sex with men, sex workers, transgender people, and people who inject drugs, report experiencing stigma and discrimination. Less than 10% of the general population reports discriminatory attitudes towards people living with HIV. Less than 10% of health workers report negative attitudes towards people living with HIV. Less than 10% of health workers report negative attitudes towards key populations. Less than 10% of law enforcement officers report negative attitudes towards key populations. In many countries around the world, people living with HIV say that they have been denied health services due to having HIV. According to a UNAIDS commissioned systematic review, human rights interventions have a positive effect on HIV outcomes. Through community-led monitoring, advocacy, and programs to ensure access to justice, communities are critical actors in aligning HIV responses with human rights principles. The Support Don't Punish initiative, mobilized in at least 200 cities in 86 countries in 2020, is a global grassroots initiative promoting human rights-based harm reduction and drug policies. In 2020, the Global Partnership for Action to Eliminate All Forms of HIV-related Stigma and Discrimination began country implementation, partnering with governments and communities at the country level to take evidence-informed action against stigma and discrimination. Gender inequality and violence. This target area emphasizes the importance of ending violence against women, girls, people living with HIV, and key populations. Gender-based violence is but one manifestation of gender inequality, which reduces the ability of women and girls to protect themselves from HIV. It perpetuates a gendered distribution of caretaking responsibilities and diminishes the educational and employment opportunities of women and girls. The new target also recognizes how unequal gender norms contribute to the vulnerability of key populations. The targets aim to achieve by 2025 less than 10% of women and girls experience physical or sexual violence from an intimate partner. Less than 10% of key populations, for example, gay men and other men who have sex with men, sex workers, transgender people, and people who inject drugs, experience physical or sexual violence. Less than 10% of people living with HIV experience physical or sexual violence. Less than 10% of people support inequitable gender norms. Greater than 90% of HIV services are gender responsive. Nearly 1 in 3 women worldwide have experienced physical and/or sexual violence in their lifetime. The experience of sexual violence often begins at an early age. About 120 million girls are estimated to have suffered some form of forced sexual contact before the age of 20 years. Key populations are frequent victims of discrimination and abuse, with more than half of sex workers in 8 of 36 countries with recently available data reporting having experienced violence. In 4 of 17 countries with survey data, more than 20% of gay men and other men who have sex with men reported experiencing violence, and high rates of violence against transgender people and people who inject drugs have also been reported in the limited number of countries with relevant data. The experience of intimate partner violence in high HIV prevalence settings increases the risk of acquiring HIV for women. Women living with HIV who have experienced violence also have reduced access and adherence to treatment, lower CD4 counts, and higher viral load. Cash transfers have been shown to help girls stay in school, increase the use of health services, delay sexual debut, reduce early marriage and teen pregnancy, and lower the risk of girls acquiring HIV. The engagement of faith leaders in gender transformative approaches in the Democratic Republic of the Congo and of men in reproductive and maternal health in Rwanda have been associated with reduced sexual violence, improved contraceptive use, enhanced women's antenatal health, and the more equitable division of labor within households. In summary, the targets for removal of societal and legal barriers, or TENs, fall into 3 categories: punitive laws and policies, stigma and discrimination, and gender inequality and violence. The high levels of HIV service targets called for in the 2025 targets can only be achieved within an environment where people living with HIV and people at risk of infection feel safe to utilize those services. The 2025 targets emphasize that countries must invest in specific efforts to remove these impediments and establish an enabling environment that is free of political, legal, and economic barriers. The achievement of these targets is central to progress across the full array of ambitious targets for 2025 and towards realizing the vision of 0 new infections, 0 discrimination, and 0 AIDS-related deaths. The third domain, service integration, focuses on adoption of people-centered and context-specific integrated approaches that support achievement of the 2025 HIV targets and result in at least 90% of people living with HIV and in individuals at heightened risk of HIV infection linked to services for other communicable diseases, non-communicable diseases, sexual and gender-based violence, mental health, and the other services they need for their overall health and well-being. It should be people who are the guidepost for designing, delivering, and assessing health services. One way to make health systems more people-centered is through service integration, with the goal of providing people-tailored, co-located, or well-coordinated services that are optimally convenient, seamless, and easy to navigate. Health integration aims to improve health program performance across 4 dimensions: efficiency, effectiveness, equity, and responsiveness. Integrated approaches that yield benefits not only for HIV but for other health priorities have the potential to generate broad-based health benefits and enable the pooling of budgets across sectors. Integration of HIV with other health services, such as maternal and child health care, tuberculosis care, primary health care, family planning, and sexual and reproductive health services, can increase uptake of HIV and other health services, improve retention of people living with HIV in care, achieve equivalent or improved treatment adherence and viral suppression, generate spillover health benefits, and reduce AIDS-related and non-AIDS-related mortality. Deciding when, how, and to what degree to integrate should build on a thorough analysis and understanding of the health system environment and of the needs of the people who utilize health services in a particular setting. Even in a more integrated system, specialization will and should remain an important element. To be effective, integrated approaches require concerted efforts to strengthen health systems, including ensuring that health policy frameworks support service integration in a manner that is people-centered. Health outcome monitoring and the agility to change course as needed in response to problems or opportunities should be prioritized. Effective HIV care and support must be comprehensive and holistic, as people living with or at substantial risk of HIV often have health issues other than HIV. A comprehensive approach that highlights all aspects of health, physical, mental, and emotional, is critical to successful outcomes. Adolescents can benefit from youth-friendly services that provide a broad array of youth-focused services. For women, introduction of point-of-care technologies for HPV testing as part of a test-and-treat approach would be inexpensive and easy to implement alongside HIV services. For men, providing HIV testing alongside screening for non-communicable diseases offers a potential strategy to improve testing coverage. Integration service packages specifically designed to address the health needs of key populations can be delivered, especially at service sites with proven capacity to deliver non-judgmental, community-tailored services. In too many countries, user fees deter access to HIV services, increase inequities, impoverish entire households affected by HIV, and increase AIDS-related morbidity and mortality. Specific efforts are needed to ensure that the move towards universal health coverage reflects the key attributes of the HIV response, including community engagement, inclusive governance, accountability for results, and a commitment to human rights and gender equality, that all services provided either in a facility or a community setting are free of stigma and discrimination, and that service packages include essential HIV diagnostic, treatment, and prevention services. Many migrants face an uphill struggle in accessing health and HIV services. There needs to be concerted legislation that creates an enabling environment for migrants to access services regardless of their status within the country. Legislation passed by Portugal to pave the way for regular and irregular migrants to access full health services provides a working model of service delivery that can be replicated elsewhere. In summary, the service integration target focuses on adoption of people-centered and context-specific integrated approaches that support achievement of 2025 HIV targets and results in at least 90% of people living with HIV and in individuals at heightened risk of HIV infection linked to services for other communicable diseases, non-communicable diseases, sexual and gender-based violence, mental health, and the other services they need for their overall health and well-being. The 2025 targets place greater emphasis on the removing of societal and legal impediments to service delivery, and on integrating the provision of HIV services, which are people-centered and context-specific, with the other services needed by people living with HIV and communities at risk, including young people and key populations, to stay healthy and build sustainable livelihoods. Let's take a closer look now at adolescents, young people, and key populations. WHO defines adolescents as people 10 to 19 years of age. Young people include adolescents and generally refer to people 10 to 24 years of age. Adolescence and young adulthood are marked by rapid developmental, psychological, social, and structural transitions. Adolescents and young people are underserved by HIV services, have high risk of interruption in treatment, and suboptimal continuity of treatment and adherence. Adolescents have special requirements for comprehensive care, including psychosocial support and sexual and reproductive health care, and may face significant barriers to accessing and remaining in treatment care and support services, often due to policy and legal barriers related to the age of consent. Key populations include people who inject drugs, gay men and other men who have sex with men, transgender people, sex workers, and people in prisons and other closed settings. Around the world, key populations face much higher rates of HIV and AIDS than the general population and are most at risk for contracting HIV. UNAIDS estimates that between 40 to 50% of all new HIV infections occur between individuals in key populations and their immediate partners. Underreporting is common within key populations due to stigma, backlash, and discrimination. Adolescents and young people from key populations are at significant HIV risk, higher than that of their older peers in these populations. Adolescents and young people from key populations are even more vulnerable than older cohorts to STIs, HIV, and other sexual and reproductive health problems. Adolescents from key populations may face stigma, discrimination, and violence even greater than that faced by older people from key populations. Stigma and discrimination may come from healthcare workers, law enforcement officers, teachers, employers, parents, religious leaders, and community members. Young MSM and young transgender people face particular vulnerabilities due to stigma, discrimination, criminalization, familial rejection, homelessness, bullying, social isolation, and violence that increase their HIV risk and produce systematic barriers in access to services. Adolescents from key populations may experience power imbalances in sexual relationships that limit their ability to use condoms. There is a large-scale absence of adolescent and youth-friendly HIV and broader healthcare programs and policies, which means that adolescents and young people are further disadvantaged in having to navigate healthcare systems and regulations designed for adults. A key focus of the UNAIDS Global AIDS Strategy 2021 to 26 is a focus on key and priority populations, including young people. There are three key result areas focused on youth. First, primary HIV prevention for key populations, adolescents, and other priority populations, including adolescents and young women and men in locations with high HIV incidence. Second, Adolescents, youth, and adults living with HIV, especially key populations and other priority populations, know their status and are immediately offered and retained in quality, integrated HIV treatment and care that optimizes health and well-being. And third, young people are fully empowered and resourced to set a new direction for the HIV response and unlock the progress needed to end inequalities and end HIV and AIDS. A focus on youth is emphasized under priority actions to promote equitable access to effective, innovative, and quality combination HIV prevention that includes PrEP, treatment optimization, and care services with a focus on key populations and priority populations, including Indigenous populations, migrants, adolescents, and youth, through active civil society engagement and social contracting initiatives. A focus on youth is emphasized under Strategic Priority 1, maximize equitable and equal access to HIV services and solutions. There are 4 priority actions to achieve the targets. 1. Address the multiple needs of adolescent girls and young women by scaling up combination program packages, which link effective HIV prevention services with programs that address HIV and sexual and reproductive health, including contraception, comprehensive sexuality education, prevention of schistosomiasis, sexually transmitted infections, gender-based violence, and sociocultural gender norms, and which promote women's empowerment and meaningful engagement. Strengthen access to good quality, gender-responsive, age-appropriate, comprehensive sexuality education services, both in and out of school, which address the realities of adolescents and young people in all their diversity, in line with international guidance, national laws, policies, and context. 3. Intensify outreach to young and adult men and increase their access to and uptake of HIV prevention, testing and treatment programs that are adapted to their needs, including voluntary male circumcision and male sexual, reproductive, and other healthcare services. 4. Intensify the quality and coverage of HIV prevention among women, especially adolescent girls and young women, including in family planning and antenatal services. A focus on youth is emphasized under Result Area 2. Adolescents, youth, and adults living with HIV, especially key populations, know their status and are immediately offered and retained in quality, integrated HIV treatment and care that optimizes health and well-being. Other priority populations know their status and are immediately offered and retained in quality, integrated HIV treatment and care that optimizes health and well-being. Some barriers to adolescents and young people accessing health services include consent requirements, unwelcoming environments, judgmental providers, financial barriers, low health literacy, lack of confidentiality, lack of involvement in the decisions that affect their lives, and limited adolescent competency and skills of care providers. Particularly for those under age 18 years, policy and legal barriers related to age of consent often prevent access to a range of health services, including HIV testing and counseling, harm reduction, and other services provided specifically for key populations. Such barriers also limit adolescents' ability to exercise their right to informed and independent decision-making. Some facilitators to adolescents and young people accessing health services include meaningful involvement in identifying and assessing their own needs, fact-based, fun, and non-stigmatizing comprehensive sexuality education and HIV prevention education, relevant, innovative approaches and platforms for reaching and providing services, commitment to human rights and gender equality, including challenging harmful social norms that act as barriers to individual agency, decision-making, and well-being. Next, we will present some peer-driven models of care. The Zvandiri As I Am program is the first of its kind in Africa. The program is a comprehensive, layered, differentiated HIV service delivery model for children, adolescents, and young people. The program has shown reductions in death and treatment failure after sustained follow-up. Since 2004, Zvandiri has evolved from one support group in Harare into a comprehensive model, combining community and clinic-based health services and psychosocial support for adolescents and young people with HIV. Zvandiri provides a package of differentiated services for children, adolescents, and young people with HIV. Services are primarily led by trained, mentored adolescents and young people with HIV known as Community Adolescent Treatment Supporters, or CATS. CATS provide peer-led services across the HIV cascade, supported by healthcare workers, social protection officers, Zvandiri mentors, and implementing partners. CATS provide information, counseling, and support for other children, adolescents, and young people with HIV through home visits, clinic visits, support groups, and mHealth. Services are fully integrated within national systems and service delivery across the HIV care cascade. The Zvandiri model brings to scale holistic support of children, adolescents, and young people with HIV that is responsive to their medical, developmental, and psychosocial needs. Model development required various complementary factors that created a window of opportunity for scale-up and continued support. In particular, to assure sustainability, the program was nested within existing services with capacity strengthening of national, regional, and local service providers and trained, mentored CATs supporting their peers, families, and communities. Zvandiri is arguably the largest national differentiated service delivery model for children, adolescents, and young people with HIV in Southern Africa. This program adds to the growing body of evidence demonstrating the effectiveness of targeted, peer-led, differentiated care delivery models in improving HIV care outcomes among children, adolescents, and young people with HIV. The CATS model shows high rates of HIV testing, 80%, ART uptake, 97%, retention in care, 99%, viral load testing, 90%, and viral suppression, 99%. In addition, the program improved the quality of adolescents' lives through its focus on shared experiences, role modeling, and supportive friendship. Improved the HIV and treatment literacy of adolescents and their caregivers. This helped adolescents better manage adherence and build self-esteem. Fostered more sympathetic household environments, with caregivers better educated and more responsive to meeting adolescents' nutritional and physical needs. And finally, led to adolescents feeling better cared for, less isolated, and less worried about the implications of their HIV status. The Key Populations Investment Fund, KPIF, is PEPFAR's $100 million initiative to expand key populations' access to and retention in HIV prevention and treatment services. The KPIF includes funding for Indigenous, community-based, KP-led, KP-trusted, and KP-competent organizations. KPIF focuses on specific KP, including men who have sex with men, sex workers, transgender individuals, and people who inject drugs. KPIF is designed to support both proven and innovative community-led interventions around critical enablers, including provision of direct services that fit into program objectives that overcome barriers to improve accessibility, acceptability, uptake, coverage, effectiveness, and efficiency of HIV services for key populations. The funding stream has 5 focus areas. 1. Scaling up demand and access to quality and effective HIV services for key populations. 2. Structural barriers that inhibit access to quality and effective HIV services for key populations or undermine their effectiveness. These include barriers in laws and policies or their enforcement, education, or economic barriers. 3. Addressing and monitoring stigma and discrimination at individual, community, and national levels. 4. Promoting human rights and justice for all. 5. Collecting and analyzing data for key populations and subpopulations. The new UNAIDS 2025 targets fall into 3 categories: comprehensive HIV services, removal of societal and legal impediments to an enabling environment for HIV services, and people-centered, context-specific service integration. New testing and treatment targets for 2025 adopt ambitious 95% objectives. They also clarify the need for achieving these targets within each subpopulation of people with HIV. Sexual and reproductive healthcare services for women with HIV and women at elevated risk of HIV infection are prioritized, as well as eliminating new HIV infections among children and ensuring that children with HIV have timely access to services. Prevention targets include all subpopulations and age groups and aim to achieve 95% of people at risk of HIV infection using appropriate, prioritized, person-centered, and effective combination prevention options. The targets emphasize that countries must invest in specific efforts to remove societal and legal impediments and establish an enabling environment for HIV services. The targets focus on adoption of people-centered and context-specific integrated approaches that support achievement of the 2025 HIV targets and result in at least 90% of people with HIV and individuals at heightened risk of HIV infection linked to comprehensive services needed for overall health and well-being. Adolescents, young people, and key populations are underserved by HIV services, have high risk of interruption in treatment, and suboptimal continuity of treatment and adherence. The Zvandiri program in Zimbabwe demonstrates the effectiveness of targeted, peer-led, differentiated care delivery models in improving HIV care outcomes among adolescents and young people with HIV. KPIF's investment in local CSOs stands to yield high returns. KP-led, KP-trusted, and KP-competent organizations are rapidly evolving to be even better positioned to respond to the HIV epidemic and the KP individuals they serve. Here are several reflection points for you to consider. In the context of your city and country, what do you think about the UNAIDS 95-95-95 targets? Do you think they are achievable by 2025? The UNAIDS 10's targets call for less than 10% of countries having punitive laws and policies, less than 10% of people experiencing stigma and discrimination, and less than 10% of people experiencing gender inequality and violence. Do you think that these targets are important, measurable, and achievable? The UNAIDS Global AIDS Strategy 2021 to 2026 calls for a focus on young people and key populations. Can you think of some ways that this focus might be achieved? Acknowledgement. The authors wish to acknowledge the fast-track implementation team, UNAIDS, Geneva, Switzerland, for peer review of this material. Thank you for your attention and participation. This is the end of this presentation.